This conference will now be recorded.
All right. How did everybody feel about their test? It was there? Not good? Okay, not good. All right. Any questions on the test? Prone on the nose. All right. So we're going to get through this real quick, and then we're going to go through scenarios. Whenever we're done, Chaz is going to stay in here, and you guys are going to do what you were doing out there where you toss the little plush heart around. And then we'll pull people out while we're doing that. There's a BVM with ventilation of an apneic adult setup. We're going to do a medical scenario and then a trauma scenario. So practice scenarios. All right. So hematologic and renal emergencies. What's hematologic? The blood issues. Yeah. Okay. So our objectives today, review the components of blood. That should be review because we went over that. What is the majority of our blood made up of? Plasma. Learn signs and symptoms of renal emergencies. What's our renal system? Kidneys, yep. And then identify how some hematologic emergencies can present in patients. So that'll be fun. All right, so blood, it represents its own organ system. So there's a lot that goes into our blood. It does a lot for us, obviously. It has specific functions. Does anybody know what some of those functions are? Transports oxygen and nutrients. Gets rid of waste. Clotting. Yep. Fights off infections. Good. I think we hit all that. All right, what is blood made up of? Red blood cells, white blood cells, platelets, plasma. Good. Perfect. All right. So when our blood clots, so what happens, right? So we get an assault or injury to our vessel. And then our little platelets, the collagen that sits on the other side here lets off little hormones that says, hey guys, this is a problem. So all of our little platelets start to clump up together. And then we get our clot, and it's held together by a fibrin mesh. So this all comes from our clotting cascade. That's a whole nother hour-long lecture. But basically, we need calcium. We need to keep our bodies at the right temperature. And then we have to have the red blood cells. So this comes into importance next week, whenever we start going over like bleeding and shock management. That's like a big thing that we're going to review. So, little blood clot. So, aggregation, all our platelets are coming together. And it is our body's most rapid response to bleeding. So, that cut happens, and immediately our blood's like, all right, we got to stop this. And then our clotting factors produced in our liver. So, this becomes important to know because if somebody has chronic liver problems, do you think it's going to be easier for them to clot or more difficult? Yeah. And then once the clotting cascade is activated, those little clots form, and then our body starts to heal. Okay. There's a lot that goes into this. This is like very basic coverage of it. So coagulopathy, this is what we use, the term we use for like an abnormal clotting of blood. It's a big word, coagulopathy. Whenever we start going into trauma, that is part of our trauma diamond of death or trauma triad of death. Coagulopathy is one of them. So abnormal clotting of blood. We want our blood to clot in trauma, right? Hopefully, because we want to stop that bleeding. So whenever we're talking about coagulopathies, the clot, is our patient clotting too readily or too easily? Are they getting over clotted, or are they not clotting quick enough? So different diseases can make patients prone to poor clotting. We talked about the liver disease. Why the liver? Yeah, so our liver produces our clotting factors. What is hemophilia? Yeah, yeah. So most of these patients that have hemophilia, there's different types. And von Willebrand is like part of our like clotting cascade, like the little fibers. So if somebody has a deficiency in that, they have von Willebrand disease. So patients with this, they have their own clotting factors that they actually inject into themselves whenever they get injured. So whether they have those factors on them or there's a specific hospital that they have to go to that carries their factors, that is also important information to obtain whenever we're dealing with a patient like this. I think I've had one patient in my 10-year career that had this. He told me he didn't have any kind of med alert, and we actually got called because he didn't have, it has to be injected into the vein, and he didn't have a needle to inject it. He had his factor, but he's like, I can't like give it to myself. And he had gotten hit on the side, and his bruise was like ginormous. It was wild. So another thing that might affect how our patient clots is if they're on blood thinners. Does anybody want to take a stab at certain names of blood thinners? Nope. What's that? Plaxius? Plaxis? Yeah, I think it's called Plavix. Yeah. But yes, good. What else? Huh? Coumadin? What else? Mm-mm.
I heard somebody else say the one that starts with a W.
Warfarin. Yep, that's one. So, Eliquis or Apixaban, Warfarin, Plavix, or Clopidogrel. Oh, so if your patient has that in their history, why isn't aspirin considered a blood thinner? Yeah, it's a blood slippery.
Yeah.
Good job.
If you ask a patient if they're on blood thinners and they tell you yes, make sure they clarify which ones, because a lot of the older generation assume that aspirin is a blood thinner. And so if you're like, if you ask them what blood thinner they're on, a lot of them would just tell you aspirin. So make sure you clarify that with them.
So it's important to know this whenever we're dealing with like any kind of trauma, right? Why? Yeah, so it makes it easier for them to get things like a head bleed. This is a picture of a head bleed. If they just fall and like barely bump their head and they're on blood thinners, they're at more of a like possibility of something bad like that happening, or internal bleeding. So those are things to be mindful of, especially when you're dealing with like car accident patients or granny that fell in the shower. If they're on a blood thinner, they need to go get checked out. What is this? We'll say we're pulling it down. What is the color of this right here? Yeah, their eyes pale. What color should this be? Yeah, like pinkish red, right? So if you have a patient and their little mucous membrane looks like this, what might be going on? Anemia. Yep. So anemia is the lack of normal red blood cells. So there's different things that can cause anemia. So acute anemia, that's something that happens like right now. That's like, it's not a chronic issue, it's acute. So sudden blood loss from whatever way they might be losing blood, whether they lop their arm off, whether they're having an ectopic pregnancy, whether they're having a GI bleed. This is something that you can kind of assess that kind of tells you what's going on. And then there's the chronic anemia. So some females deal with it with heavy menstrual period or heavy menstrual bleeding. Sometimes it gets bad enough that they need to go get transfused, whether it's with like an iron infusion or like a blood infusion. What is this? Yeah.
Do not believe that you'll never see this.
Yeah.
I got told, and Becca got told in our EMT classes, like, oh, you'll never really see this. And then we moved to Atlanta, and every other patient in Atlanta had sickle cell. So
there was whole parts of the hospital that was dedicated to sickle cell. So we would go on a sickle cell patient, take them to their hospital that they wanted to go to, and we would take them directly back to the sickle cell center. So the cells get sickled, right? So it is a genetic disease. It's most common in African Americans. So they can carry the trait. There's different traits. If you ever have a patient with sickle cell, they're going to be very knowledgeable about what's going on. They can tell you like, oh yeah, I have type S or type SS, and they can go into way more detail than I ever could. So these patients know what's going on with them. They've been dealing with this since birth. So their cells have a short lifespan and they lead to chronic anemia. There's some other things that could happen if they have sickle cell. So these patients are in pain for the majority of their life. They're on like chronic pain treatment regimens. So if they are calling you for pain, this is like their like normal day-to-day life is like a 7 out of 10 pain. So if they're calling you for pain, there's something else going on, right? If they're like doubled over, can't walk, 10 out of 10 pain, they need an ER. They need to be treated. This is actually a genetic disease that was like adapted to deal with malaria. So there's like a little evolution that went on. Their bodies tried to adapt to malaria or being able to like, live through malaria. And then now it's a genetic disorder. There's some like fancy long term for that. So here's a sickle. That's why it's called sickle cell, because it's the shape of that tool. So some complications of sickle cell. The biggest one that you'll see if you live in a part of the country that deals with this a lot is the pain crisis. So what happens is those sickle cells clump up and they stop blood flow to whatever organ is affected. So you'll have patients with like presenting as a heart attack, presenting as a stroke. A lot of times their spleen is affected, and then it also settles into their joints. So like we worked with somebody that had sickle cell. He chronically was like a 7 out of 10 pain in his hips. It can cause their eyesight to go away. It can cause their kidneys to fail. So this is all stuff that you're going to obtain like in your assessment, right? So like what's going on, what's your pain regimen, where does this normally affect you? Because usually whenever they have a pain crisis, it's like affected the same area throughout their whole life. So acute chest syndrome, that's where they get like the shortness of breath, their heart, their chest pain. You still want to do a 12 lead on them, no matter the age. So there's horror stories out there of 8-year-olds in sickle cell crisis that are having a stroke and a heart attack at the same time because of their sickle cell. Priapism, that's a bad day for them. And then jaundice, if they're jaundiced and have sickle cell, what do you think's going on? Yeah, their liver's affected. So for your treatment for a sickle cell patient, it's going to be oxygen if indicated. So these patients, most of the time, their SpO2 reads low anyway, just because of how their cells are shaped. And then if you can call for ALS to get them some pain management on board, that is preferred. So renal system, here it is. What are the components? We have our kidneys, our little lima beans, right? What space do they sit in? Yeah, retroperitoneal. Yep, retro. So remember, retro, throw back, they sit in the back. And then there's the ureters that come down, leads to our bladder, and then the urethra. So whenever there's a kidney stone, it likes to travel through here, and that's the painful part, right? So if the kidney stone's hanging out in the kidney, most of the time people don't even know they have them until they start moving. So our kidneys, they filter everything for us. So they filter from our blood. So what happens is they have like these little loops of Henle in there, and whenever we give somebody like a diuretic, it affects that. So they'll pee out more stuff. So all your pee is just waste. Removes salts, fluid, certain electrolytes. It's maintaining the balance of homeostasis in our system, right? So if there's any kind of mess up with these kidneys, you get backup of fluids, you get backup of bad electrolytes, or too many electrolytes. There's a lot of stuff that can go on, and we'll talk about that. So some diseases, UTIs is the most common one that you're going to deal with. What is a UTI? Yeah. What kind of demographic of patient do you think that we see is going to be most commonly affected by a UTI? Females, yeah, because their urethras are so short. Nursing home patients, huge demographic. Foley catheters, any kind of catheterization of the urinary system is going to give you a higher chance of getting a UTI. Usually it's in the bladder. If it spreads up, it can go into your kidneys and cause like more problems. This word, pyelonephritis. So whenever it goes up into your kidneys, bad day. What are the signs and symptoms do you think you'll see? Back pain, fever, belly pain, smell.
It is a very
frequent
distinct
urination.
smell.
It is a very distinct smell. Once you smell one, you'll smell them
It's not a joke.
from there
It
on
is a
out.
very distinct smell, and you will know it when you smell it.
Yeah. And then, so either inability to urinate or frequent urination. Most of the time, if someone knows that they have one, they'll know that they have one, and it's very uncomfortable. What is this? Yeah, kidney stones. Huh?
If you drink a lot of Monster,
Yeah, hydrate yourselves. So made from calcium, formed within the kidney. We talked about when they're in the kidney, there's usually no symptoms. And then unilateral flank pain. What does that mean? Yeah, it's one-sided. And then sometimes it can like radiate. So it can radiate down to the groin, radiate across their back. What's a good way to what's a good assessment you can do for kidney stones? Does anybody remember? I think we talked about it on Tuesday. You can tap their back. You tap right above their kidneys, and if they're like, it's not a good day. That's why, because look how sharp those things are. I wouldn't want to pee one of those out, that's for sure. If they get bad enough or too big, they'll actually go in with like, I can't remember what it's called, sonic something, ultrasonic waves. Yeah, they'll like break them up so they can become easier to pee out. What is this?
Mama Troy's favorite thing.
Yeah, it's a Foley catheter.
This is every nurse's favorite thing.
Yeah, they're like, do we have a catheter? Man, we don't have a pulse.
Yeah.
So this part goes into the bladder. This little balloon here is inflated once it's in the bladder, and then the urine drains out into this. If you're transporting a patient that has a Foley catheter, please note how much they have, how much urine output they have when you get there. And then I always just say like the color and condition of the urine, because if they have a UTI, what kind of color do you think it's going to be? Dark. It can be like cloudy, icky. Sometimes you'll see like sediment in there. It looks like sand is in there. What if it's like brown? What are we thinking? Blood. What else? Dehydration. There's a big one that we haven't really touched on yet. It's really rhabdo. So rhabdo is whenever your like muscles start to break down, whether it's like a patient that fell and was in the same spot for a really long time, or like these people that go out and run marathons or don't hydrate themselves and overexert their bodies.
Like old David Goggins.
Yeah.
He's famous for going into rhabdo.
Yeah. That's a big one. So there's a bunch of reasons why somebody would be put on a Foley catheter. acutely, if they're like put into a medically induced coma, they're going to be put on a Foley catheter. But then there's also like chronic conditions that can cause it. I almost said cystic fibrosis, but that's not it. Multiple sclerosis is one. Sometimes they just have like their bladder just doesn't work, so they have to use catheters.
And you'll see most of these if you go out for like hospice patients, bedridden patients, paralysis patients, people that just generally have issues getting to a bathroom. They just go ahead and put Foley catheters in them because it's easier for them just to Foley than it is for them to try to ambulate in and out of a bed to go to the bathroom every time.
Mm-hmm. Please be mindful whenever you're moving a patient that has a Foley catheter not to rip that sucker out. I've never seen it. I don't want to. Like, imagine that balloon that's inflated just rip out. No.
I have had a patient cut theirs in half though.
I have had that. They have to deflate that balloon and then
He said it got too full and it was dragging on his pecker, and he got tired of freaking the thing dragging on his pecker, so he cut it in half. And I was like, all right, well.
Yeah.
So whenever that happens, if they have a home healthcare nurse that is able to come out and replace it, that is an option for them. But what's a big issue that you think is going to happen if that's not rectified? Infection is the biggest one, right? Because that's a direct line inside the body with no filtration systems. So be mindful of that. If there's any sort of like, cuts, tears in their catheter line, either they need a home healthcare nurse to come out there and fix that immediately, or they need to go in and get it changed out.
Can be placed through the skin too. So whenever we talk about that, there's something called a suprapubic catheter. So they put like a little hole here and it goes directly into their bladder. I don't have as much experience with those as Foley's, like seeing them. So something like that, you want to look at like infection around the area. Anytime there's a hole, like a tube inserted into somebody, you want to look for infection around the area. You're still going to note like the drainage that comes off of it, all that stuff. If they're yanking on them, there's going to be trauma at the site of insertion. So there it is in a male. You can see like where the little balloon is inflated in the bladder. All right. Renal failure. So kidneys not working, right? So those kidneys can't work. They can't remove those toxins. So there's a bunch of different things that can cause renal failure. And whenever you get further, you're going to learn things like pre-renal failure and all this stuff. If somebody goes in shock for a long time, their blood pressure's too low and their kidneys aren't perfused, renal failure. You have somebody that unmanaged diabetes for a very long time, renal failure. Uncontrolled hypertension, renal failure. There's a million things that can cause this. So whenever we're dealing with patients pre-hospitally, if you're treating their blood pressure, that's what we're trying to save, right? We're trying to save their major organs. So that's why we're aiming for like a MAP of 65. Because does everybody remember what MAP is? It should be on that vital sheet that you guys got. It's the mean arterial pressure. So mean arterial pressure above 65 and above, you're saving those kidneys. And that's what we're looking for. So the doctors that deal with all this stuff, they're called nephrologists. And just a little fun fact, I was doing my clinical rotations for paramedic school, and I asked one of the neurologists, I was like, so which doctor is like the head honcho of the hospital? Like, who calls all the shots? And I'm expecting him to be like, oh, cardiology, or oh, us, like neurology. No, he was like, it's nephrology. Like, the people that deal with the kidneys are like the head honchos. They're like, don't give this med, do this, kidneys. But it's important, right? Because that's how our bodies maintain our homeostasis. So, can be inherited. Yeah, renal failure. Then there's end-stage renal disease. So they get like percentages of what their renal function, like how well their renals are functioning. So this is irreversible renal failure. So at this point, if they're in end-stage renal disease, they're going to be on like dialysis. And usually it's done like 3 times a week, right? So what kind of things do you think we're going to see if somebody misses their dialysis appointment? Swelling. What else? So you have a buildup of fluid, right? Sepsis, edema. Yeah, edema. So you can get edema in the legs, in the chest, hypertension or hypotension, depending on like electrolytes, right? So there's two kinds of dialysis. There is hemodialysis. So they go in and like take out the blood from a vein and the artery, and they circulate it, clean it, and put it back in. And then there's peritoneal dialysis. What do you think that is just by breaking down this word peritoneal? Go ahead.
It's where they stick where the build up fluid and abdomen.
Mm-hmm. Yeah, so they put fluid into their peritoneum, which is that lining in our stomach, right? And they let it sit for a little bit and then drain it out.
You know
Not as
somebody that's
common.
on peritoneal dialysis? No.
No, I just watched a YouTube video when I was here studying that type of stuff.
Yeah, that's good though.
I like it.
Not very common. So 90% of your patients on dialysis are on hemodialysis, and they go to centers for it. So we don't have any in Battle Mountain, but you'll see like these big dialysis centers.
I don't know. Is it Winnemucca? They shut that one down, didn't they?
They shut down by Talon out there?
Yeah, I'm pretty sure because I just had a conversation with somebody about this. It might have been, was it Miranda that I talked to about this? I don't know. I had a conversation with it because I think the only dialysis center we have in the area anymore is Elko.
Yeah, they shut down Winnemucca. Winnemucca had like a hit and miss one for a while, but
Yeah, I think they shut that one down. And I think the only dialysis center around here now is Elko. But understand, if you run into these dialysis patients and they're at the point that they're calling you and they've missed dialysis, 2 or 3 times, these folks are going to be very, very sick, very ill. They're not going to be breathing well. They're going to look like crap, and you're going to need to get them out of here pretty quick. So,
And do all of the things. Treat the hypoxia, do the 12 lead, call for ALS, all that fun stuff. If you work in like a bigger city that has a bunch of dialysis center, you will become very familiar with dialysis centers because we go there all the time. Either they stop it because the patient started getting sick during their dialysis, or they didn't even start it because their blood pressure was too low before they started it. There's a plethora of reasons that you get called, but you get called there a lot. And they're sick.
and it's always freaking, what's the name of that? DaVita?
DaVita, yeah.
Freaking hate them people.
Yeah, DaVita.
I mean, they're good
dialysis.
for the people.
Yeah. So only 8% of patients actually treat themselves at home, but it can be done. So depending on, it's not as common to run these kind of calls. This is what a dialysis center looks like on the inside. They all get these really comfy little chairs, and then they get hooked up to this machine. They do their little dialysis, and then they go home. If you work for like a non-emergent transfer company as an EMT, a lot of these transfers are set up that you take them to and from the dialysis center. So that's also another thing to note if you want to do that. Here is a picture of hemodialysis. So goes in the vein, in the artery. You can see they get one catheter for each. Comes in, it cleans all their blood and puts it right back in them. I'm throwing things. So somebody that gets hemodialysis all the time gets a special procedure done, and they have something special put usually in their arm. Does anybody know what that's called? A fistula, an AV fistula. So this is what a fistula, it can look like this. Sometimes you see it and it looks like a squiggly little snake. If your patient had this, true or false, I can take a blood pressure on that arm. False. Why? It can be in the way. Damage it. Yeah, so you don't want to damage these. So avoid IVs in this arm. Avoid blood pressures on that arm. Whenever you feel a pulse, like in that area, you're going to feel like they call it a frill. So if you ever have a patient with it, try and feel a pulse on that arm, and their pulse feels weird. because of that fistula. A thrill? Okay. I couldn't remember if it was frill or thrill. It's something,
Something ill.
it'll feel real fun. And then there's also a 2-port catheter. So keep in mind that these 2-port catheters, they're a huge source of infection, right? Because this is a tube sticking in their body. Anytime you have a tube sticking in somebody's body, you want to be very, very mindful of like the caps on these and that kind of stuff, because that's a direct line into their arteries. So be mindful of that kind of stuff.
Whenever you're looking at these patients, a lot of times these fistulas in their arm, if something happens to it, they'll remove it and place it in the other arm. So if you ever run into these patients and their one arm just looks all whacked up and janky, and then their other arm also, because after a while you'll see these patients and they'll get these big like nodules on their arms, and it just looks unhuman. And I say that as nicely as I can. But they get these giant nodules in their arm, and their arms get all knotted up and stuff. Some patients, after if they have any issues with these, can get them removed, put in the other arm, and then you're able to use that arm for blood pressures. Sometimes, a lot of times, by the time they get ready to remove them, they're too knotted up and gnarly, and they just don't work anymore. So a lot of these patients, you're just going to have to go below the elbow and get blood pressures off their forearms. So ask these folks. They know what arms you can take blood pressures in, what arms you're not able to. So be mindful of it, because they do this 3 times a week. So just talk to them.
Mm-hmm. All right, and here's your peritoneal dialysis. So they got these little tubes. They put in the fluid, let it sit, and then they drain the fluid. If you ever get called for somebody that has this going on and they're having like a dialysis issue, sometimes they'll have like bags of their fluid, and you can take it with you to the hospital. So there's different types. There is CAPD, and then there's CCPD. So the CAPD, it happens throughout the day, several times a day, and then the CCPD happens at night while they sleep. I don't know very much more than that. I've had one patient with this, and it was this one. So
was it me and you that ran on the one that their machine was acting up?
yeah.
Yeah, and they were like, fix it. And I was like,
That
I'm
is
not
not a
going to do
me
that.
thing.
Yeah.
Yeah.
Yeah. So just load these folks up and take them to the ER. I mean, it sucks, but yeah. They did. They were like, "Can you fix this?" And I was like, I'm not gonna touch that." And it was freaking. But
yeah,
they generally speaking, the family and or patient knows more about these things than you do, and that's okay.
Mm-hmm. Yeah, you'll run into that a lot. So, all right. So, complications and medical emergencies whenever it comes to renal failure, end-stage renal disease. So keep in mind that a lot of these patients, they have more than one thing going on. So a lot of times there's something that caused them to go into renal failure, whether it's the hypertension or the diabetes, but then they could also be having complications of like the actual dialysis, the backup of fluid, those kinds of things. So keep that in mind whenever you're assessing these patients, because 98% of the time, our patients don't have just one thing going on with them, right? So check the blood pressures, check the sugars, do the 12 leads, all that kind of stuff. I'd say the most common complaint that you get for somebody from a dialysis center or somebody that's on dialysis that I've dealt with is like dizziness. And usually it leads to the hypotension because they took too much off of them. So they are hypovolemic. All right, so signs and symptoms, we talked about them a little bit. Y'all said buildup of fluid, shortness of breath, anything else? Yeah, edema, lower high blood pressure. Yep. What about like lung sounds? What do you think you're going to hear if someone has backup of fluid? Yep. Crackles. Yep. Good. So very similar to congestive heart failure. because there's a backup of fluids. So shortness of breath, edema, whether it's pulmonary edema or pedal edema or sacral edema, just peripheral edema. And then electrolyte disturbances is the big one, because whenever they can't get that potassium off of them, if anybody didn't know this, whenever there's a buildup of potassium, that's actually what they use to kill people in lethal injection is potassium. So too much potassium in the extracellular fluid will kill the crap out of somebody. And then we have to talk about our like bacterial infections at those sites. So we talked about like those ports, but then that fistula, every time they go into dialysis, it's accessed. So infections, make sure you're looking at the site, any redness, swelling, hot to the touch, that kind of stuff. And then peritonitis, what is that? Yep. And what kind of signs and symptoms do you think will be associated with that? Fever, pain. Yep. There's the edema.
Ugh.
Ooh.
Why his toe look like that?
Yeah. All right. So if you see this, that's bad. Okay. What do you think's going on there? Infection. Yeah, it looks icky, right? So yeah, check for sepsis. If your patient meets SIRS criteria, get them going. So another thing that you might see is bleeding from that fistula site. Sometimes you get called to the dialysis centers for that. Sometimes people just like start bleeding when they're at their house. And when you get there, it looks like a murder scene, because that is like AV is arterial venous. So it's connected directly into their artery. So whenever we talk about arterial bleeds, they bleed a lot, right? Chaz talked about the loss of function at that site. They do get all knotted up and icky.
How are you going to control that if you get paged out to somebody? Let's say they had an accident working in the shop and they accidentally cut that fistula. How do you feel like you can control that situation?
Squeeze it, crimp it, stop it from flowing out.
Yeah. So a lot of times a tourniquet really is not a terrible option for these things if all else fails. I have seen one of these things damaged and they will bleed a lot out of these things and they will kill the crap out of them.
Mm-hmm.
So just be mindful of that. If you ever get paged out to somebody that has a bleeding fistula, expect to walk into a very gnarly looking situation.
Mm-hmm. There's the clamp you were talking about.
Yeah.
So at the dialysis centers, they use these fancy little clamps because they're trying to if you put a tourniquet on above it, you're going to cause more damage to the fistula. So they use these clamps to just like pinpoint that source of bleeding and stop it. This is like a very nice picture of what it actually looks like. Every time I've dealt with this, there's blood everywhere. What kind of shock do they go into? Hypovolemic. Good. So direct pressure, elevation, hemostatic dressings if you got them. What is hemostatic dressings? Yeah, it's going to help stop the bleeding. And then if you can't get it to stop by those means, apply your tourniquet. All right, kidney transplant patients, most commonly transplanted organ. They get this very distinctive little scar on their belly. 21,000 transplants per year.
Does she got a trumpet on her tum-tum?
She does have a trumpet on her tum-tum. So kidney transplants, say that you go on a patient, they say, yeah, I had a kidney transplant 5 years ago. What are some things that you want to ask that patient? Yep. There's a certain like list of medications that they get put on to help with like rejection. So that's a big thing to ask for. So they also have an increased susceptibility to infections because like there's foreign things in them, right? And then their immune system goes down. So keep that in mind if you're ever dealing with somebody with kidney. There's also a chance that kidney is failing. So if they're showing signs of like renal failure, like that backup of fluid, keep that in mind too. I'm pretty sure that I could be wrong on this, but I'm pretty sure whenever you get like a kidney transplant, They don't take out your old kidneys. They just put like a new one in there. There's three. There's three because you got the two and then the new one. I don't know exactly how they do it. I can figure it out for you, but from what I've heard, unless these are like so diseased, like that they're causing more problems, they'll just pop a new one in there, so you get like a bonus kidney. Maybe. Yeah. Yeah, that's a good question. I will find out. I don't know. Maybe. I don't know. I will do more research and I will have an answer for you. Yeah. All right. I don't know what that means. All right. What questions do you guys have about renal, hematologic, anything? Nothing. Mhm. Mhm. Like a blood pressure?
What's the kidney worth?
Like 30,000.
Oh, like a new fistula in their leg? That's a
Also
really
a
good
kidney.
question. I don't know. I've never seen a fistula in a leg. Maybe they would just like go to like a port at that point, but I'm not 100% sure. Let me, I'll have to research that one. I need to make a list of things. Yeah. Have you ever seen a fistula in a leg? No. What if like this one fails and this one fails? They just put in a port?
I think so.
No, I don't know.
I had never seen them
That's a
in the
good
leg
question.
and the forearm. I have seen them in the forearm before.
Yeah. Maybe they just moved down like forearm. Yeah,
Yeah.
maybe. Yeah.
Those fistulas are nasty.
I don't know. I don't know.
It was interesting.
It was interesting. For sure. Yeah.
All right.
The general
Austin,
consensus was that COVID looked like shit.
Kim is going to hang out with y'all, do some things.
There is a patient in Battle Mountain that receives peritoneal dialysis. Interesting. Oh, okay. Google says they keep the old kidneys and then they have 3. Yep, time for
Time
assessment.
for assessment.
Perfect. Do you guys have any questions down there in Austin? Yes, they are.
They're figment. I've only seen them like one time.
Awesome. Thanks, guys. I'm going to stop the recording.